Good evening. My name is Lisa Wadsworth, and I look forward to providing you this course this evening. I'm glad you've joined me. You know, don't you agree that one of the attributes we cherish most is our smile? It has been said that the most valuable asset that we possess and cherish is our smile. It defines us and provides us our identity. We greet the world with our smile. Quite frankly, it boosts our self-esteem and our confidence. Our mouth and teeth provide us with our ability to eat, nourish our bodies, even breathe and sleep correctly. We communicate and show our affection, all the things that bring us joy and wellness. I am spurred on with my professional passion for dental implants because I am a patient of successful implant surgery, or therapy as I would rather call it. This therapy improves, rebuilds, and often saves lives. So as we look into this evening on proper dental implant maintenance, just wanted you to know a bit about where I come from in my passion for implant dentistry. I want to thank Sonicare, Philips Sonicare Oral Health Care, for helping sponsor this evening, giving me the time to prepare and bring this to you this evening. So Philips Oral Health Care, thank you so much for the opportunity. So where do we begin? We have dental colleagues. I have dental colleagues, and the statement below is not true from me. It's not my sentence. But to me, it's very valuable in how we present dental implants to our patients. The most natural replacement for a lost or missing tooth. Doesn't that sound better than a screw or a fixture? Doesn't the most natural replacement for a lost or missing tooth sound more inviting and something that patients would want to have in their treatment therapy? There are differences, and there is hope, health, and healing behind implant therapy. What do I mean when I say that? Hope is brought to children who may have been born with genetic syndromes such as anodontia and may be born without the capability for primary or permanent dentition. Throughout most of their lives, up until the last 5 years, the technology was not supported to help those children with dental implants and provide them with mini implants often in the beginning of their life, and then incorporate dental implants natural size as they grew and became older. So it brings hope to children who may not have the complement of their own dentition. It can bring health to those who've lost their teeth to periodontal disease. We can restore health, but within that setting, we know that maintenance, education, and patient compliance is most important. And dental implant therapy also provides healing. Think of our patients who've suffered trauma from a car accident, any type of accident where they've lost teeth, or from those patients who suffer from cancer of the head and neck and oral cavity and may lose an entire mandible or at least some dentition in the process of care. Through hope, health, and healing of dental implant therapy, we can help these patients come back to a fruitful, viable life, rebuild their self-esteem, and, quite frankly, save their lives. So where do we begin with our patient education, and who should be involved? I think where it should begin is with all of us. Implant therapy is a team approach. Certainly we start with our dentist, and they aren't even on my slide. Most important members of the team go beyond the dentist. They go to the registered dental hygienist, the dental assistant, and even our administrative team members. When should we begin? At the phone call that we receive about an interest that a patient may have in implant therapy. So all members of the team should be able to field questions on the phone and bring a passion or instill a need, an urgency for patients to come to our office to discuss their possible use of implant therapy. It is a team approach. Why is it so important? Implants are often misunderstood. Dental implants are sometimes thought of as still in the testing stages, and this is so untrue. They're an expected part of our therapy today for our patients. And who plays a role again? All of us. But we know that there are significant differences between natural dentition and implant therapy. 3 are represented on the slide. We know that our natural dentition has a blood supply. Implant therapy, or dental implant to bone osseointegration, does not have a blood supply. We know that our natural teeth have the complement of a periodontal ligament and those 13 pesky Sharpie's fibers. Our implant therapy does not have a periodontal ligament and just has a thin perimucosal seal, which you'll hear about later. And our natural dentition have mobility. They're suspended in a pocket with the complement of the periodontal ligament, and they are mobile. Our implants should be totally rigid down to a microscopic level. Therefore, they are ankylosed. If you'll think of it as a dental implant as being similar to an ankylosed tooth, the implant and the bone are one. It's called osseointegration. So here we go, thinking about implant maintenance. We don't have to reinvent the wheel. Some things are very similar, and I like to call what we have now in our patient base is mixed dentition of a new kind. Instead of thinking about primary and permanent dentition mixed together, think that oftentimes implant maintenance also is being done in the presence of natural teeth as well. So we have to think about our mixed dentition as natural and the most natural replacement for a lost or missing tooth. We'll be discussing frequency, tissue tone, instrumentation, the stability of our implant and the prosthetic that goes on above it, the polishing products that are safe for us to use in a clinical setting, and what polishing products our patients can use at home, and what steps are most important for oral hygiene at home for our patients. We do have a lot to guide them through, and we do have much to cover for our own clinical inspection. Implants usually have the same components. They have the body of the implant, which is the titanium fixture, or what we can call the root of the implant prosthesis. We have an abutment, and oftentimes, at least until the last 10 years, we had a screw that came down into the internal hex of the implant. Nowadays, many prosthetics, or the crown portion of the prosthetic, is held in place by cement. And boy, have we heard a lot about this during the last 2 or 3 years. Many research papers have been written about the importance of total removal of cement around your final placement. The body of the implant, it represents or replaces the root of the tooth. It enables the attachment of the prosthesis above the gum line, and it's usually made, or most commonly made, of titanium. Some implants now are made of ceramic, but for our purposes today, we'll be discussing and placing most emphasis on the titanium surface of the implant that may be visible during your maintenance visit. Prosthetics come in all shapes and sizes. I think the slide on the left is a bit funny. we certainly wouldn't be asking our patients to use 5 pieces of tufted floss, but as you can see, some prosthetic components can be very complicated. On the left, you'll see a fixed case on the maxillary arch and a fixed case, if you will, or not removable case on the bottom. Or you might see what looks like very similar to crowns. We might not even realize that underneath these crowns are implants instead of natural roots. So no matter what the prosthetic component looks like, it's up to us to decipher whether it's well, whether it's healthy, unhealthy, and what we need to help our patients with at home and what we will have to do clinically. The perimucosal seal. This is one of my favorite slides. I'm so intrigued by implant dentistry and what this slide represents that I really could hang it over my bed. What we see in this photograph is a healthy perimucosal seal, which in the case of an implant, is the periodontal pocket. What we see is a healthy rim of gingiva, again in the middle, and again on the right. Some areas have keratinized tissue, as we see here, and some do not have the complement of keratinized tissue. But the most important thing to remember about this seal is this is the pathway to jawbone. It's the pathway for bacteria, for our instruments to reach beyond where we should and communicate through one small, thin, horizontal fiber and reach the jawbone. Therefore, we must realize that implant dentistry can break down much more quickly than natural dentition when attacked by bacteria. Inside the perimucosal seal, remember, there is one silly fiber and not 13 Sharpie's fibers as we have within our periodontal pocket and set up for natural dentition. The perimucosal seal is the most important thing to maintain when we move forward in implant maintenance. The roles we share in implant maintenance are critical between the patient and the provider. We must do our job by being diligent with safe probing, using the correct products around the type of prosthetic, and taking radiographs which complement our clinical ability to judge health and maintenance. Health versus periodontal disease is a microbiological difference. And there are differences. Why do implants fail? They fail because of peri-implantitis and some same reasons that natural teeth fail. This slide, as you can see on the lower left, is from 2003, and the graph shows that at the time the feeling was that 70% of failures were caused by peri-implantitis and that only 30% were caused by occlusion or all other factors. We now know that occlusion is moving up the scale in importance or reasons behind why dental implants fail. So you will hear during this presentation that occlusion and prosthetic design is very, very important to the health and longevity of implant therapy. Poll question number 1. Shall we do one? Poll number 1. Do you feel you understand and could explain the importance of the perimucosal seal after that definition? We're getting quite a lot of responses. How do you feel? Do you feel you could understand and could explain the importance of the perimucosal seal? Votes are still coming in. Okay. I think I'll close the poll and let you see the results. As you can see, 64% believe that we could explain the seal, and 22% thought you might be able to explain the perimucosal seal. I think if we have some question about the perimucosal seal, let's address it now. The thing to remember, the difference is with a natural dentition, we have the complement of a periodontal pocket. Within that pocket, in health, it ranges from 3 to 1 millimeters. We have Sharpie's fibers, we have connective tissue, and it is adhered to jawbone. In the perimucosal seal, we do not have a connection directly to the jawbone. We have one single fiber that runs in a horizontal surface, and beneath that goes directly to bone if we probe too hard, if we use improper instruments within the seal, or we use products at home that we shouldn't use. So, for a prosthetic assessment of the implant maintenance, we should be checking our occlusion now at least twice a year by the dentist. What that means for us hygienists or assistants is that we should be prepared with blue paper and have the dentist check the occlusion. If we have high spots or anything is loose, it must be corrected immediately. The breakdown in occlusion or improper occlusion can cause failure of our implant case. So to check for mobility, if we have 2 or more implant prosthetics, we should, such as a 3-unit bridge, we should take an instrument such as a scaler, place it under the embrasure of the prosthesis, and pull up on it. If we feel any movement, we must determine what is mobile. Is it simply the prosthetic or the crown on top, or is it the dental implant itself? If we're checking for mobility and stability of a single implant, we should use 2 stable instruments, one on the buccal, one on the lingual, such as the end of a mirror, an oral mouth mirror. We look for healthy tissue. What do we look for? Both of these photographs show something quite different in the mouth. We see here our crowns, which could have natural teeth under them, or implant therapy. But the tissue tone, the color, looks wonderful. It's pale, it's pink. Where we have attached gingiva, we have stippling. Where all we have is our titanium bar, we don't have the complement of any papilla, the tissue tone still looks wonderful. It's pale in color. It is fibrotic here. Everything looks healthy. And the contour, again, for our implants is good. We have height in our papilla, which means that we have bone underneath this point. Do we have to have a complement of attached gingiva? It's a question I receive many times. As you can see in this photograph, the first 2 teeth do have the complement of attached gingiva and keratinized gingiva. The last 3 have no attached gingiva and not really any keratinized tissue either, but it still looks healthy, and we must document our findings in the chart. Remember, documentation is key. If we don't document it, we didn't do it. And we now have intraoral cameras in our operatories, so hopefully we can even document our studies and our looks for clinical stability with photographs. A look into unhealthy tissue, it looks very similar to periodontal disease with natural dentition. We have red coloration. We even have purple discoloration. We have suppuration, as you'll see down here on the distal. The tissue tone looks glossy, and we do have bleeding on probing. And another very important word in unhealthy tissue, or any time we're clinically observing implant dentistry, is if there's any pain at all, we know that we have trouble. The first type of beginning of a problem that you may think of as gingival inflammation, just as gingivitis, the word for the syndrome around implant dentistry is called peri-implant mucositis. It's usually caused by inadequate oral hygiene, possibly the restorative choice that sits on top of implants where the restorative piece is removable, and it also can be caused by loose abutments or the part of the implant prosthetic that sits on top of the titanium fixture in the jawbone. The good part with peri-implant mucositis is that it is contained within gingival inflammation and there is no bone loss. Peri-implantitis, however, moves us into the realm of periodontal disease. It means periodontal disease around our implants. We do have bone loss. We might have to surgically intervene with these patients, and we have a name for what is going on around our implants in peri-implantitis. We can have classifications of peri-implantitis such as early, moderate, or advanced. Ailing, failing, failed are other common names for peri-implantitis, the amount of involvement in bone loss. So what do we do with patients who have peri-implantitis? The doctor should be brought into the case immediately. It may mean that surgical flaps are necessary. It may mean that chlorhexidine rinses are necessary, oral irrigation in the office and at home. We may even use antibiotics in the oral cavity as well as systemically for the patient. This may include a surgical flap and sutures and the addition of bone graft material back into the site to help regain osseointegration and the implant becoming one again with the jawbone. What does peri-implantitis look like on a radiograph? What we see are dark halos around the implants, which tell us that we have lost bone around the implants. This is a large case that has failed, and the natural dentition has failed with it also. But an important thing to note why it possibly could have failed is this black line between the root of the implant, the body of the implant, and the crowns on top of it. If you see a space on your radiographs, this means that your prosthesis above it is loose and it must be addressed immediately. Or what can happen is the rocking and the mobility of the prosthesis on top will cause total bone loss around your implants. So what do we do in another goal of implant therapy assessment? We have to probe carefully. We must use plastic instruments, go along the axis of the implant, use very little force, and don't blanch the tissue. These are all good comments to make, but how do we know what force is too much? We know when we're blanching tissue, but oftentimes being able to get along the axis of an implant and probe carefully or correctly we're not able to do that around some prosthetic designs. So I caution you to probe carefully, use plastic instruments, very little force, and sometimes probe only if you need to know more information. Again, we're dealing with the perimucosal seal, and if we probe in a harsh manner, we can break through this seal and reach right onto the jawbone below. We probe for a baseline at placement of a final restoration. The depth is not important, but change in depth is important. So again, we must document, document, document. If we don't document our findings and our depths of the pocket, we didn't do it. After 1 year, we only need to probe buccal and lingual only, because we can see through radiograph evidence how much bone loss we have lost or not, how stable we are through the use of radiographs. Remember, there's one silly little fiber, and we must protect it at all costs. We do our interproximal assessment with radiographs by utilizing bite wings or PAs. The crestal bone is most important. Why? Most implants will fail from crestal bone downward rather than from the apex upward. And we count our threads. We want our radiographs to be diagnostically useful. We can see the threads in this radiograph here. You want to make sure that you can see them in every case and that your technique is reproducible. So, poll number 2. Do you feel more confident about the need for careful probing? Start the poll now. Do you feel more confident about the need for careful probing? Good. We're getting some answers in. Moving along quickly. Okay, I think we're ready to close the poll, and you can see the results. Good. You seem to have many people a little bit more confident about the need for careful probing. So, with radiographs, what do we want to accomplish with radiographs? We need a baseline film at placement of prosthetics, and then periapicals 6 months to 8 months out. For the first 2 years, we want to take radiographs every 6 months. Once we've had a year clear with no change in our periapical films and what they tell us, we can change to vertical bite wings to cut down on the number of radiographs that we may need to check on our implants. If we have no changes after that year, we can think of our radiograph protocol as we do with full mouth series, every 3 years. And remember again that the crestal bone is most important to our assessment. Diagnostic quality is most important. This is a fabulous example of a diagnostic quality x-ray. We can count the threads 1, 2, 3, 4 all the way up almost to 15, and we document if our bone height has decreased or moved apically during our radiographic assessment. Interesting that one thread equals about 1 millimeter. So we can count our threads, if they're not covered with bone, to allow us to document how deep, what bone loss we've had. Remember that we want a view of the crestal bone is most important. Remember, for our maxillary films, we do have a sinus to contend with. The apex might be critical in the maxilla, and we want to be able to see the thread counts. I show you this film for you to consider that this may not be a quality radiograph for our diagnostic tool. So make sure that your radiographs are high quality. If you have to retake them before you present them to the patient and to the doctor. This is a fabulous x-ray of what you do not want to see. Again, we discussed the black line, which separates the prosthetic top piece from the bottom titanium fixture in the jawbone. If we see this, we must immediately engage the doctor into taking off the prosthesis, finding out what's causing it to be loose, and putting it back in place. Occlusion and mobility. We talked in the beginning about the importance of checking occlusion at least twice a year with our blue paper and having a drill ready if we need to change or soften the occlusion. And if we have any mobility in our prosthesis or in our assessment, we have to determine whether it is the implant itself, the titanium implant in the jawbone, or if it's simply loosening of the prosthesis on top. The removal of the superstructure is interesting. In 10 years ago, even 5 years ago, we thought it best, clinicians thought it best to remove the superstructure every year, inspect the titanium implant in the jawbone below it, and then replace parts and put the prosthetic back in place. Now the thinking is that we should not remove the superstructure unless we feel we have a problem, unless we're seeing mobility, feeling mobility, or have a gingival problem. Bars and clips will be part of our assessment, and dental hygienists and assistants, members of the team, it would behoove you to learn how to take our O-rings out and replace them, or the clips in our hater bars. But before you remove them, make sure that you have replacement parts in the office, and possibly even take these parts out, label them on your bracket tray cover, and know what size goes back in what place. Don't ask me how I know this. It's from a not too humorous story of not having the things I needed to replace what I took out as far as O-rings and hater clips. So do yourself a favor and know that you have what you need, and do know how to properly remove the O-rings and clips and put them back in place. Poll number 3. Are you following this protocol with respect to placing parts and checking occlusion? I'm going to start the poll now. Are you following this protocol with respect to replacing parts and checking occlusion? Getting quite a few answers in now. I'll keep it open a little bit more. Okay, I see we may have some questions at the end about this portion. You can see the results. I think we'll probably have a little more discussion about this at the end of the lecture. All right, clinical aids in treatment. This is for our benefit as clinicians. What's safe? What may change? Remember to ask your manufacturer about their products and join a group. The way that what has helped me in my path in clinical dentistry with implant dentist therapy is I joined a national or international group which meets twice a year for international meetings. They provide education not only for the doctors, but for assistants, hygienists, and administrative teams. They provide education without bias, without politics, if you will, but pure research, pure literature to help us understand what is considered safe now. What might have been safe yesterday may not be safe tomorrow. When may we look for a change? And what manufacturers are here to help us? So let's start with implant hand scalers. There are many, many types on the marketplace. There are implant scalers made with titanium, gold, acrylic, graphite, many different types of instruments made out of many, many different types of metals or products. What we do know now is that the most safe scaler for round implant therapy is plastic. There are many on the market from many different distributors and manufacturers, but remember right now that what is considered safe by leading research and those in the industry who do the research is that plastic is the safest scaler around implant dentistry and the cosmetic dentistry that might be living next to it. Ultrasonics and piezos, I'd like you to read your literature. Some of the ultrasonics and piezos are safe around titanium and porcelain. They are very useful to us in a clinical setting because they create a lavage, which means that they introduce oxygen into that perimucosal seal that is similar to the periodontal pocket. It creates the cavitation, which can remove endotoxins. The whole goal of ultrasonics and piezos is to safely remove and disrupt the biofilm. But we do want to make sure that we are using ultrasonics and piezos that are meant and are safe for use around dental implants, as well as our cosmetic dentistry that might be close by. Our implant power scalers, which are part of either our piezo or cavitron selection, are seen here in this slide. We have many different companies to choose from. You can choose the ones that are most comfortable for you, but again, I encourage you to simply make sure that you are talking to the manufacturers, you're visiting the distributors at dental shows, you're asking the question, is it safe around implant dentistry? May I see the research? Can you lead me to the research about the safety and efficacy of the use of these units around implant dentistry? Oral irrigators are safe in our clinical setting and at home for our patients. What is important is to make sure that it is on a low setting, and we ask that the tip be placed directly through the contact and not aimed down into our sulcus or down into the perimucosal seal. We want it direct through the contact and on a low setting. You may ask what's safe to use within the oral irrigators. Safe solutions are simply warm water. If we want to take it to the next level and know that we're having bacterial kill, we can use chlorhexidine either in its own concentration or mixed with water. Or safer is not safer in killing bacteria, but safe for all patients is an alcohol-free rinse. You may even use a fluoride rinse through your oral irrigator. All are safe around dental implant therapy. Our polishing agents in our clinical setting should either be a gel toothpaste, tin oxide. Remember the big tub of tin oxide powder you have back in the lab that's been there since dental school? It's a nice fluffy white powder. You mix it with water in a dappen dish and use it on your prophy cups, and it will provide you a nice, safe polishing agent for titanium as well as any ceramic or porcelain that may be nearby. You can choose to buy an implant polishing paste from your manufacturers, but you want to use a fine prophy paste should you choose a prophy paste. I tend to stay away from prophy paste and use tin oxide and use a soft cup. Fluorides in the office, we should be aware that we should be using fluorides that do not contain acidulated phosphate. Acidulated phosphate can etch titanium if you have any titanium exposed in the mouth. Make sure that you're reading the manufacturer labels and that we do not have acidulated phosphate in what we're using in the office or asking our patients to use at home. Sodium fluoride or neutral sodium fluoride would be of choice. We know that neutral sodium fluoride will not affect the surface of the implant, and it will not affect the surface of ceramics or porcelain nearby. Poll number 4. Are you more confident now with respect to types of instruments and aids to be used with titanium fixtures? We conduct our poll. Start our poll. Are you more confident now with respect to the types of instruments and aids to be used around titanium fixtures. You see quite a good number coming in feeling very happy about what we're learning and what choices are important. Okay, I'm going to close the poll and I'll show you excuse me, the results. There are our results. So I think we are, as a group, more confident with respect to the types of instruments and aids to be used around our fixtures. So, what are we going to send our patients home with? Let's review first what we as clinicians can use safely around dental implants. We know we can use piezos, we can use cavitrons as long as they're deemed safe by literature for use around implant therapy. We can use oral irrigators. We can use plastic instruments. And we can use plastic probes. So now that we've sent our patient home, it's important that they understand and have had buy-in with what they need to do at home before they leave the practice. Toothpaste should be non-abrasive, non-whitening, and they should be a fine paste or gel. I prefer to use a gel simply because I know that there will not be any grit of any kind within the toothpaste. We need non-abrasive and we need toothpaste that are non-whitening. Even the manufacturers of some of our types of toothpaste that are considered homeopathic often now have whitening agents. We want to steer clear of whitening agents and of abrasive particles. I can't stress that enough, whether we're using it with a manual toothbrush, which is considered safe to use around dental implants. Manual toothbrushes should be extra soft, ultra soft right after our surgical portion, but at least extra soft throughout to continue the longevity of the implant prosthesis. Manual toothbrushes work really well as long as we know that our patients are capable and have the dexterity to use a manual toothbrush effectively at home. Electric toothbrushes are deemed safe and effective around dental implants. Literature does support the use of electric toothbrushes around implant therapy, but please speak with the representative or the manufacturer about the type of electric brush that you're going to give to the implant patient. I would choose the upgraded model of any electric toothbrush, no matter the manufacturer. The upgraded models have better bristle quality control. Again, the upgraded models have a better quality and quantity of bristles that will be safe and effective around implant therapy. Ultrasonic toothbrushes are my favorite simply because the research shows that whatever product is placed onto the sonic brush will be driven farther than the surface of the head of the brush. It will actually force your gel toothbrush paste or your fluoride solution further interproximal than the electric toothbrushes might. So electronic toothbrushes are safe around dental implants, but I would go one step further and steer you toward an ultrasonic toothbrush. They are both safe for use around implant therapy. Power floss devices are now on the market. They haven't been there for many, many years, but they are there now and they are of value to us. The two on the slide are the water pick and the air floss. These two are both safe for use around implants. They are safe for use around porcelain. They are safe for use around cosmetic dentistry. They help our patients floss without having to deal with winding floss around our fingers, worrying about the dexterity of our patients at home. The Power Floss devices and our ultrasonic and electric toothbrushes are real value when we think we may have a problem at home with the dexterity of our patients. It's not just about the convenience of an ultrasonic or an electric brush. It's really about the dexterity that the patients need to have when working with these products at home. Interproximal brushes and end-tuft brushes, we know that we must have the internal portion of these devices covered in plastic. There should be no metal exposed which could rub on or against the titanium fixture and cause scratching. So our most important part here is to make sure that anything that we use in the mouth is plastic. What would you choose for your patients? Would we choose interproximal brushes? Would we choose some tufted floss that we have to thread up and over the prosthetic? We can use stimulants, and we can use our travel end-tuft brushes and our travel go-betweens. My trade secret is white acrylic yarn. What do I mean by that? Instead of asking our patients to purchase expensive floss, which is different gradients of fuzz and flat, or Teflon, which are all good, they all work, but sometimes all we need around our implant prosthetics are a piece of white acrylic yarn cut into strips similar to floss, and use them as sort of a buffer or a big piece of floss to go between our prosthetic cases. Why do I mention the need for acrylic? If we use cotton yarn, you will feel as though you've swallowed a gauze square. So make sure that you advise your patients to use white acrylic yarn. Where did we go? Hi, we're back. My trade secret, white acrylic yarn. So I like to buy a spool of white acrylic yarn and hand it to my patients when they're going home for the first time with their new prosthesis. Remember, through it all, whatever products we use that are safe and effective around dental implants, what we're trying to maintain is our perimucosal seal and the safety of the implant in the jawbone. Implant dentistry is expected, not experimental. And I'd like to open it now to questions. I see that we've already had some. I see a question, does the air floss work interdentally? Yes, the air floss does work interdentally. Let's see, we have another question. Does it matter what type of head on that ultrasonic brush? I would like you to think that you would use the type of brush that would be best suited for your patient's oral cavity. If you have a patient with a large mouth, certainly use the full head. If you have someone with a smaller mouth or someone who, I like the small ultrasonic brush head. You pick up another question. We have quite a few questions here. Is there a concern about acidulated phosphate with fluoride varnish? check with your manufacturers. I don't know what is contained in all fluoride varnishes. Some, I would not think there would be acidulated phosphate within a fluoride varnish, but I would please check with your manufacturers to know whether it's safe or not. Fluoride varnish really don't need to use around dental implants on the titanium, but I do understand you might be using them on the natural dentition in the same mouth. I think we have another question. What's the reason behind not using whitening toothpaste? Whitening toothpaste often are whitening or are able to whiten your teeth because they have grit. They have some form of grit that allows it to polish superficial stain off of your teeth. And anytime we have anything that could scratch a titanium surface, that is a worry to us. So stick with gels or toothpaste that are very, very fine. Here's a long question. When providing prophylactic treatment on a patient with an implant, is it necessary to change out both Prophy code and implant maintenance code? Or would it just be the Prophy code unless... All right, this is an insurance question. I really am not at liberty to discuss insurance questions and what you should do or not do, but what I will tell you is that there are Prophy codes for perio maintenance, there are Prophy codes for healthy mouth, and you can add to that an implant maintenance code. You can charge, there is a code for implant maintenance. Whether you choose to use it is at your discretion or the practice philosophy. But what is good to note is that if we don't use proper coding, if we don't code for what we do, the companies will not realize that we are providing this service, and in the long run it will not help our patients have any benefit of coverage for the procedures that we're doing. So it would be my idea to code correctly. It's up to you whether you charge. You can always place a code and not charge for it. But I think it could be important to use correct codes. When using the team approach when treatment presentation, it is proven that the patient is more open to the dental assistant. So is it important to make sure the dental assistant is exposed to continuing education on implants to be comfortable? Absolutely. The international group that I discussed with you, you can find it on my website, has education for every member of the team. We know as dental assistants, I started my life as a dental assistant, that we are asked more questions in the privacy with patient than even the hygienist and certainly the dentist. The dental assistant, if you are not exposed to implant therapy in your current practice, go visit a periodontist, go visit the oral surgeon, and see what's happening in these practices. Absolutely. Very important. How do I feel about using ultrasonic scaler to flush interproximal? Wonderful idea. Just make sure that either your ultrasonic or your piezo is safe for use around implant cases. But absolutely, yes, it's great to flush interproximally. Here's a good one. Where can I get white acrylic yarn? Good point. Not in the CVS or the Walgreens. I find it at craft stores or knitting stores. And go in and ask for white acrylic yarn. It's very reasonable. A whole spool is somewhere less than $4. Okay. Transient, this is a good question too. They're all good. Transient, are you worried about, I believe this is what it is, transient bacteremia after brushing teeth versus implant. Now remember, our natural dentition and implant therapy both harbor bacteria, good plaque and bad plaque. So we do worry about transient bacteremia after brushing tooth versus implant. The bacteria is the same. The bacteria in our mouth is the same and can cause harm around implant cases much more quickly than around natural dentition. Let's see. Good questions. Thank you. Very informative lecture. I hope so. I think we had some questions on the perimucosal seal or some doubts about that. Just remember, it's one silly fiber. It is not a complement of 13 fibers, the Sharpie's fibers like we have around natural dentition. So that's the reason for all the research and the dedication to safety and efficacy of what we choose to use as clinicians around implant dentistry and the porcelain that may be used on natural dentition nearby. Last question, do you sterilize the acrylic yarn? Yes, you can. I've had that more than once come up in lectures. If you want to sterilize, cut up pieces of acrylic yarn, place them in pouches and sterilize them for your patients to take home, they will make it through the sterilization process. I want to thank you so much for this evening. I think we have time. It's again another question about implant maintenance codes. Look into the code books and you will find a code for implant maintenance and also for the care and exchange of O-rings and hater bar clips. Another question, having a hydro floss in the office to use on patient in office and to show them how to use it correctly is an excellent idea. Correct? Yes, absolutely correct. A point that I did miss in the very beginning, we must have total buy-in from our patients on the importance of implant maintenance before we even sign the case. Why? Most patients who are going through implant therapy have lost dentition because of periodontal disease. So they're not used to being able to perform, or not motivated, shall I say, to perform oral hygiene at home. So absolutely, anything you use or ask them to use at home, make sure that it's been demonstrated in the practice so that you know that they're able to do it at home. It's a critical piece and important for all members of the dental team to understand and be able to instruct your patients with. Thank you so much. I'm so glad to have been here. Thanks again to Philips Oral Healthcare, and feel free to contact me on my website, lisawadsworth.com.